I'm going to, with great pleasure, introduce my colleague from Georgetown, Dr. Tara Suntum. Dr. Suntum did her medical degree at the University of Maryland. She's local Montgomery County raised. Then she went to Richmond, Virginia, to do her pediatric and internal medicine residency there at the Medical College of Virginia, and then off to Chicago to do her pediatric oncology, hematology oncology fellowship at the University of Chicago, a really well-established and has a number of very famous people who've made a lot of good discoveries there. So with no further ado, I'll welcome Tara. Thank you. Please welcome Tara.
All right. Thank you to the organizers for having me today. As Jeff mentioned, I'm from Georgetown. I'm a pediatric oncologist there, and today I'd like to speak about the importance of small round blue cell tumors as it relates to our adolescent and young adult cancer patients. So to just make sure we're all on the same page, who are our young adolescent and young adult patients? So these are patients that are defined by the NCI as being between ages 15 to 39 years of age when they're diagnosed with cancer. And this came about after an observation in the late 90s, early 2000s, that there was a lag in survival improvements for this age group. So this graph here is from SEER data over a 20-year period, showing that the average annual percentage change there on the y-axis was significantly lower for those patients aged 15 to 39, highlighted in yellow. So this led to a pivotal AYA progress group, this and many other studies, I should say, led to a pivotal progress review group sponsored by the NCI and the Livestrong Foundation. And this group identified gaps in care for these patients and recommendations for a national agenda. Since then, there has been an increase in research focusing on this population, as well as clinical trial inclusion for these patients, programs nationally and internationally that focus on treatment for these patients, advocacy groups, and other supportive resources. And because of this, there have been improvements in survival gains since this in 2006. Despite the survival gains, though, we know that there is still a differential survival for this age group when they're diagnosed with pediatric cancers at an older age. So the graphs up on the right demonstrate overall survival based on different cancer types, and the orange column is highlighting those patients in the AYA age range. And so the top graph is showing that there are some cancers, sorry, I don't have a laser pointer, that there are some cancers that have worse survival than both the pediatric and adult counterparts when they're diagnosed. That includes soft tissue sarcomas, non-Hodgkin's lymphoma, and some leukemias. The bottom graph is demonstrating that there are cancers in the AYA range that do worse than the pediatric diagnoses, but do fare better than their adult counterparts. And that includes Hodgkin's lymphoma, brain tumors, Ewing sarcoma, and ALL. Now, there's been a lot of research to look at why there's this differential survival in this age group, and there are several different reasons that I've listed some of them here. This includes cancer biology, familial cancer syndromes, and subsequent malignancies, which tend to happen in this age range. Increased toxicity due to some differences in physiology in this group, as well as location of care and clinical trial enrollment. There are studies in certain types of cancers that have shown that patients in this age group do better on pediatric regimens than adult regimens, and if they're not at the right center, they may end up on different chemotherapy regimens. Additionally, there's adherence issues that can come up with this group that relate to presentation and delayed diagnosis, as well as adherence to coming to their appointments and taking their medicines appropriately. Additionally, there's problems with access to healthcare. This group is the highest rate of uninsured in America, so this can often be a struggle for these patients going through therapy. And then lastly, are psychosocial stressors, which are very important for this group and lead to some of the other issues with adherence and other problems during therapy, and they require unique support compared to other age groups. So today I'd really like to focus on the cancer biology differences that we see in these AYA patients with regards to small round blue cell tumors. So what are small round blue cell tumors? So these are tumors that histologically look sheets of small round blue cell tumors, as the name says, and these are poorly differentiated cells. And so they have really large hyperchromatic nuclei and scant cytoplasm, giving them a high nuclear to cytoplasmic ratio. And while there can be some clues from clinical and morphologic appearance, we often need immunohistochemical and molecular testing to make a diagnosis of these tumors. And there are a variety of tumors that look like this. And so here's a list of potential diagnoses when we see this histologically. That includes non-Hodgkin's lymphoma, neuroblastoma, rhabdomyosarcoma, Ewing sarcoma, and PNET, desmoplastic small round blue cell tumor, or small round cell tumor, synovial sarcoma, osteosarcoma, Wilms tumor, hepatoblastoma, and retinoblastoma. So as you can see, there's a wide range of tumors that can present like this. And for today, relevant to the other talks we're going to hear for this session, I wanted to focus on the tumors neuroblastoma, rhabdomyosarcoma, and osteosarcoma as they relate to our AYA population, known biology differences, and potential implications for treatment strategies. So to start with neuroblastoma, this is a tumor that originates in the adrenal glands or the sympathetic nervous tissue, so can present in a variety of ways. It's the most common solid extracranial malignancy in children, and typically peaks in infancy with a mean age of diagnosis of 1 to 2 years of age. And then the incidence actually goes down over time for the different ages, and actually less than 5% of patients with neuroblastoma are over age 10. So this is actually one of the more rare tumors to see in our AYA patients, but nevertheless it's an important one because they seem to have a distinct phenotype. So the majority of older children and AYA patients, and we're talking about those over 10, present with stage 3 or 4 disease, and they tend to have a more indolent course, but ultimately a worse survival. And so this is some data from the INRG that is showing survival outcomes or event-free survival based on age groups. And so as you can see in the solid line at the top is less than 18 months of age, and they have excellent survival rates. However, as you increase in age, there is a worse event-free survival, and you can see patients that are over 10 years of age, the solid and dotted line at the bottom, have the worst event-free survival out of all the age groups. And this has been because these seem to be relatively refractory to chemotherapy regimens. And it's likely that this is representing a distinct underlying difference in tumor biology for these patients. So what exactly are the tumor biology differences that we know about? So one is that MYC-N amplification, which is actually a more aggressive form of the disease, it's actually less likely to be in AYA patients, so that's not necessarily one of the reasons this tumor is more aggressive. However, MKI is actually lower typically in these patients, which is associated with a worse overall outcome. These patients also tend to have lower chances of loss of heterozygosity at 1P, which does not necessarily portend differences in outcome. These patients tend to have higher rates of poorly differentiated or undifferentiated tumor, which does portend a worse outcome. They tend to have more loss of heterozygosity at 11Q and 3P, which also does not seem to portend outcome. However, they do have mutations in ATRX in about 30 to 40% of these patients, and this is a SWE/SNF type chromatin remodeling factor involved in a lot of cell processes, which has been associated with a worse outcome. They also have mutations in ALK, which also has been associated with worse outcomes. So all the ones in bold are highlighting those changes that are leading to worse outcomes in these patients. And to highlight how some of this knowledge is impacting therapy for these patients, I wanted to highlight ALK inhibitors. So as I said, these ALK mutations are more common in our older patients. And when there's a mutation in ALK, which codes for a receptor tyrosine kinase that normally leads to cell proliferation and survival, by using these ALK inhibitors that are listed on the right, including crizotinib and lorlatinib, these bind to the ATP binding domain of the receptor and inhibit this downstream signaling. and they have shown promise in some studies so far. And what's exciting is our current Children's Oncology Group phase 3 clinical trial for newly diagnosed high-risk neuroblastoma patients is including this in one of the arms. So after patients are diagnosed with high-risk neuroblastoma, their tumors are going through testing, and if they have an ALK aberration that's detected, they are receiving lorlatinib, this targeted ALK inhibitor, essentially throughout the rest of their therapy at different time points, including with their chemotherapy cycles, after recovery from autologous stem cell transplant, during radiation, during immunotherapy, and then even in a continuation phase. So the hope is that we see some added benefit by adding these ALK inhibitors to standard therapy. To transition over to rhabdomyosarcoma, this is the most common soft tissue sarcoma in children and adolescents, and it can arise at a variety of anatomic sites. And we know from prior data that there are more favorable sites than others for this tumor to arise from. And so I listed the favorable sites here, including the biliary tract, the orbit, head and neck, excluding parameningeal tumors, genitourinary tumors, excluding bladder and prostate. All other tumor sites are considered unfavorable, and there are other favorable and unfavorable prognostic factors that are taken into account, including tumor size, age, and surgical resectability, as well as histologic and molecular features. So the histology has been important. Historically, this is how the tumors were classified, and they were classified into these 4 different categories: embryonal, alveolar, pleomorphic, and spindle cell or sclerosing rhabdomyosarcoma. The embryonal and alveolar rhabdomyosarcomas are bolded because those are the most common histologies that we see in our pediatric and AYA patients. And these pictures represent the classic histology for these different types of tumors. And the embryonal tumors classically are diagnosed at a younger age and have a more favorable prognosis, while those with alveolar rhabdomyosarcoma are diagnosed at an older age and have a more aggressive phenotype. And the alveolar rhabdomyosarcoma is more common in the AYA patients. And over the past several decades, we've learned a lot more about the role of fusion proteins in rhabdomyosarcoma. So this PAX3 or PAX7 FOXO1 fusion protein occurs in about 70 to 80% of alveolar rhabdomyosarcoma patients. And this fusion protein leads to a DNA binding domain being placed next to a transactivation domain. And this leads to proliferation, angiogenesis, inhibition of apoptosis, activation of a myogenic program, and inhibits terminal differentiation. Further work by Dr. Shern at the NCI and colleagues within the COG and the Broad Institute did work to do this comprehensive genomic analysis of rhabdomyosarcoma. And while a lot of information was learned, I just wanted to highlight a few points. And that is those patients that have a fusion positive tumor, as is highlighted in the purple boxes in those rows, the majority of those had alveolar histology. However, there were some tumors that had embryonal histology or mixed histology, so it wasn't always classically the alveolar. And similarly, for those patients that did not have the fusion protein, they were majority embryonal, but there were some alveolar and mixed histologies present in that group as well. And for those patients that had the fusion protein, they had a relatively low mutational rate with less likely to have other genetic or genomic alterations. And this differs from those patients without the fusion protein that tend to have a lot more aberrations detected in the tumor. And so to just highlight the couple of takeaway points here is that it really seems like the categorization based on the PAX gene fusion protein more accurately captures the genomic landscape and the biology of these tumors than the typical histologic classification. And clinically, we've seen this as well. And these fusion positive tumors do have a lower burden of these somatic mutations. So what about in AYA patients? So I've already mentioned these tend to are more likely to be the alveolar rhabdomyosarcoma and fusion positive disease, which portends a poor outcome. They are at also increased likelihood for having an unfavorable primary tumor site, metastatic disease, and lymph node involvement, all which portend a worse prognosis. And then as for molecular differences in AYA patients, there was a subsequent study done by Dr. Shern and colleagues at the COG and the UK collaborative group, which looked at sequencing tumor tissues for patients that were on rhabdomyosarcoma clinical trials and learned a lot of information that was correlated with outcomes. So there was a difference by RAS mutations by age. So the red line in the graph here is showing that at a younger age, there were actually higher rates of HRAS mutations. And then the blue line is showing that there was more of an enrichment for NRAS mutations at an older age. This, however, did not correlate with outcomes. Additionally, there was MyoD1 mutations that were associated with an older age, as well as a head and neck or parameningeal primary site. And these mutations, as you can see in the Kaplan-Meier curve on the right, in the red line, had a much worse event-free survival than those tumors that did not have this mutation. Likewise, TP53 mutations were also more common at an older age and portended a worse event-free survival when correlated with outcome. And lastly, tumors seem to have a higher or an increased rate of tumor mutational burden with increasing age. So the figure to the right is showing somatic changes over time or by age, and the blue dots and blue line is representative embryonal histology, and the red dots and red line is representative of alveolar histology. And within both histologic subtypes, you can see that with increasing age, there tends to be more of a tumor mutational burden. And this was from the earlier study by Dr. Shern and didn't have correlations with outcome, but there have been subsequent studies by Memorial Sloan Kettering that have shown that increased tumor mutational burden in rhabdomyosarcoma did portend a worse outcome. So it's clear that there are several biology factors within the AYA patients that are leading to a more aggressive tumor phenotype. And the hope is really that this is going to impact how we risk stratify these patients and ultimately define what therapy is best for them. So right now, risk stratification and therapy assignment is mainly based on clinicopathologic features and not molecular and genetic features, except for the FOXO1 fusion status, which was recently added. So hopefully taking into account these other mutations that we are learning more about will allow further tailoring of therapies. And ultimately, this knowledge will lead hopefully to targeted agents for these tumor types, as well as development of additional targeted agents. And this diagram here just displays some potential targeted therapies for rhabdomyosarcoma in different pathways in the cell, including receptor tyrosine kinase signaling, apoptotic pathway, cell cycle, as well as the pathway activated by the PAX-FOXO1 fusion protein. And while there's many potential therapeutic targets, there's a lot of work that needs to be done to make this clinically relevant for the patients. And so lastly, I wanted to talk about osteosarcoma, which is the most common form of bone cancer in children and young adults. And the bottom graph is showing the incidence by different ages, and you can see that there is a peak incidence in adolescents coinciding with the pubertal growth spurt. There is also a second peak later in life that is related to Paget's disease, as well as secondary malignancies. And while there's been advances in other treatment areas over the past several decades, osteosarcoma is one in which we have had limited progress made in improving survival outcomes over the past 40 years, and we're still using the same therapy that was established back in the 1980s to treat osteosarcoma. And especially those patients presenting with metastatic disease have a very poor prognosis. As far as AYA patients with osteosarcoma, this was a study that looked at survival rates based on age, looking at patients enrolled on cooperative group trials in North America. And you can see that those with the dotted black line, those that were over age 18, had a worse overall survival than the age group less than 10 and those 10 to 17. This was because they tended to have an increased risk of relapse and ultimately death from their tumor. This effect was seen greatest on the localized disease, and that was mainly because those presenting with metastatic disease have a poor prognosis regardless of age. What was interesting from this study is that this worse outcome was not explained by tumor location, histologic response to therapy, or metastatic disease at presentation. So it seems like there are some other underlying factors that have yet to be established. So how does the osteosarcoma biology differ for this tumor compared to the other ones? So this is a tumor that is highly heterogeneous with a lot of genomic complexity. And the hallmark is this high genomic instability. And there's this process called chromotripsis, which leads to genomic rearrangements. And ultimately what's happening is there's shattering of a chromosome, and when it's put back together, there's a lot of these alterations that happen. And this leads to high levels of chromosome structural variations and somatic copy number alterations. And because there are so many different mutations happening here, it can be hard to discriminate driver from passenger alterations. And notably, there's few recurrent point mutations happening in osteosarcoma, with the exception of the RB1 and the TP53 gene mutations. And in comparison to neuroblastoma and rhabdo, the genomic landscape of pediatric osteosarcoma is actually indistinguishable from adult osteosarcoma. So we haven't yet seen a difference in the biology of osteosarcoma based on age. So there's probably some other factors at play. And so there's been some exciting work done by the Sweet Cordero Research Group, in which they did deep sequencing of osteosarcoma tumors to look at pathway alterations rather than specific individual gene mutations. And based on their work, they were able to classify alterations into 6 different groups based on their genomic signatures that they were seeing. And those are highlighted in this figure here, including having MYC activation, as well as one of the other pathways that is important is the VEGF pathway alterations. And with this knowledge, patient-derived xenograft models at the NCI Pediatric Preclinical Testing Consortium are doing targeted testing targeted agents based on the genomic signatures of their PDX models and using these pathway alterations. Now, the columns on the left side beneath each of the pathways represent different PDX models, and those that are highlighted in green are those that we would have expected to have had a good response to targeted agents based on their genomic signature. However, the column on the right that is shaded in color represents the response to targeted agents, and the red colors represent progressive disease. So as you can see, even though there were different models that would have been expected to respond to targeted therapy based on the known genomic signature, they are not having the response that we would expect. So that shows that we need to have more research done into what the best approach is to target these tumors. But I did want to highlight some medicine that has been shown good responses for osteosarcoma, and that's our tyrosine kinase inhibitors. And so there are multiple receptor tyrosine kinases that are expressed on osteosarcoma cells. And this diagram here is showing that the receptor tyrosine kinases can be inhibited by a variety of tyrosine kinase inhibitors, and each inhibitor listed here inhibits multiple of these different receptors. And ultimately, these receptors lead to proliferation, migration, and survival of the tumor cells, but by inhibiting these receptors, it's inhibiting those downstream signaling pathways. And so multiple TKIs have demonstrated efficacy in patients with relapsed or unresectable osteosarcoma, including sorafenib, regorafenib, cabozantinib, lenvatinib, and pazopanib. And while they had a short duration of follow-up, there was promise from these studies. So right now, there's consideration of incorporating these TKIs with other agents to augment the activity that we're seeing from these studies in relapsed tumors. And to highlight one of our patients that received cabozantinib, this was a patient who had multiply relapsed osteosarcoma and had already had multiple lung nodules resected when he presented again with multiple pulmonary nodules. And the CT scans on the right show a couple of pulmonary nodules highlighted in the red boxes, and he had several others besides these. And after 9 months of treatment, you can see that the bottom nodule went away completely, and the nodule on the right decreased dramatically. He did have to stop due to toxicity from the cabozantinib, but he has now been off cabozantinib for 2 years and has not had any sign of recurrent disease, showing promise. All right, and I wanted to end with some clinical trials and initiatives that will hopefully advance our knowledge for treatment of these tumors. And so the first is the MATCH clinical trial, or the Molecular Analysis for Therapy Choice trial, which is a precision medicine treatment trial for adult and pediatric patients with advanced or relapsed solid tumors supported by the NCI and COG. And so in this trial, tumor tissue undergoes gene sequencing, and if there is a genetic abnormality in a gene that has a targeted agent available on the trial, the patient is eligible to receive that drug through the trial. And because of this trial, many different tumor types will receive the same drug, and we'll hopefully learn more about targeted agents for many different tumor types. Another exciting initiative that just started this year is the Molecular Characterization Initiative, which is offered through the NCI's Childhood Cancer Data Initiative. And this is an initiative to promote data sharing and collection of new data for childhood cancers. And so in this trial or initiative, tumor DNA and RNA is going to be sequenced and analyzed, and that data is going to be shared with families and providers as well as researchers. And this data will be used to inform therapy options for the patient, clinical trial options, but it will also help to develop new and better treatments. So initially, this is for pediatric and AYA patients with CNS tumors, but the plan is to expand to soft tissue sarcomas and other rare tumors later this year, and ultimately to more tumors in the future. And so hopefully with this, we'll learn a lot more and improve our treatment options. So in conclusion, I hope I've convinced you that AYA patients with neuroblastoma, rhabdomyosarcoma, and osteosarcoma have worse outcomes than younger children, and this seems to be because of some distinct molecular phenotypes, at least in neuroblastoma and rhabdomyosarcoma. And that hopefully an increased focus on molecular differences in these AYA patients will lead to a decrease in the survival disparity for this group. Ultimately, the better understanding of the molecular landscape will help guide future treatment strategies. And we also need more creative agents for targeting these tumors. And it's exciting that the CCF provides support for a lot of this research, and I'm excited to hear about the research later today. And with that, I'll thank you and take any questions.
Thank you, Tara. If you have a question, just raise your hand, and it looks like Dr. Dome has the microphone. So any questions, just raise your hand, and I'll let him know where to come find you, if I can see you. It's very bright up here. Anybody? Any questions? You did a great job of summarizing. I guess if there's no questions, that's a good thing.
Great. Thank you.
And thank you very much.